Hey, happy Sunday, everybody. Welcome back to Pathagonia. This could be my last episode for a little while. I'm getting ready to go into the abyss of surgical pathology, so probably be pretty busy for the next month, but who knows, maybe I'll squeak out a video or two on the weekends sometimes. But before I start that journey, I just wanted to make a quick video on colon cancer from Kurt's notes. So let's get right into it. So for colorectal cancer, most commonly we're talking about adenocarcinoma or adenocarcinoma not otherwise specified, or NOS. So the characteristic morphology of colonic adenocarcinoma is going to be architectural complexity, cribriform growth with abundant dirty necrosis. So that necrosis filling the lumens is a classic sign for colon cancer. You can even see necrosis on a cytology specimen for colon cancer. If it's possibly metastasized to the liver or somewhere else, you can see necrosis, which can be indicative of adenocarcinoma, but particularly colon cancer. And most colon adenocarcinomas arise through the adenoma to carcinoma sequence, which is why it's so important in my last video to be able to recognize those low-grade dysplasias, the tubular adenomas, and the less worrisome polyps before they progress to carcinoma. So colon cancer is the third most common cancer in the US, and it's associated with processed food, obesity, red meat, low fiber diet, and alcohol. So there's several subtypes of colon cancer to be aware of. Although most colon cancers are NOS, not otherwise specified, some subtypes exist, and many of which have distinct morphology with clinical implications and molecular alterations. So you can have a mucinous adenocarcinoma, which is pictured here on the right. Makes sense, right? It's predominantly mucin, and that's going to be more than 50% of the tumor is composed of pools of extracellular mucin, and it's the most common subtype. There's no prognosis implications, and this is often enriched for MSI high tumors. If less than 50% is pools of extracellular mucin, then you can denote mucinous features or mucinous component, but it's not enough to make the mucinous adenocarcinoma subtype. All right, moving on. You can also have a signet ring cell carcinoma. So we can see that here on the right, these beautiful appearing signet rings. And if more than 50% of the tumor cells have prominent intracytoplasmic mucin displacing the nucleus, you can call it signet ring cell carcinoma. And this typically has a worse outcome, and it's associated with Lynch syndrome and MSI high. So MSI high, obviously we know, relates to the stability or instability of the microsatellite proteins. So those are commonly checked if a diagnosis of colon cancer is made, or actually they're more commonly being done for a lot of cancers other than just colon cancer. Let's see here. So next up we've got medullary carcinoma, so bottom right. And medullary has sheets of malignant cells with that vesicular nuclei. Kind of looks like an open chromatin pattern, vesicular appearance, with prominent nucleoli that we see here, and abundant eosinophilic cytoplasm, and a prominent inflammatory infiltrate. So you're going to see a lot of inflammation, like lymphocytes and other inflammatory cells in the background. And this often has BRAF mutations and associated with MSI high, and actually has a better prognosis, medullary does. You can also have a serrated adenocarcinoma, which morphologically is similar to serrated polyps. Or you can have micropapillary adenocarcinoma with small clusters of tumor cells with stromal retraction. This is a worse outcome, like in all organs, with early metastasis to the lymph nodes. There's also adenoma-like adenocarcinoma with pushing invasion with minimal desmoplasia, and it's hard to diagnose on biopsy, but has a good prognosis. And there's also adenosquamous carcinoma. So let's talk a little bit about grading. For NOS cancers, it's based on gland formation and the least differentiated component. Don't include areas of tumor budding or poorly differentiated clusters. These are counted elsewhere. So for the grade, you have low grade or high grade. Differentiation, you can have well differentiated, moderately differentiated, and poorly differentiated. And then you report or grade based on gland formation. So if it's over 95% gland forming, low grade, well differentiated. 50 to 95% gland forming, low grade, moderately differentiated. And high grade, poorly differentiated is less than 50% gland formation. So I guess it's more well behaved and well differentiated if it's maintaining that glandular formation. And once it starts to stray from that, it's a higher grade and poorly differentiated. Kind of like in a lot of other cancers, right? If you think about prostate cancer, once it starts to be sheets or cords or single cells, then it's a worse grade. So some special data to report for colon cancer. You can have large venous invasion, and that's when tumor involving endothelium lined spaces with an identifiable smooth muscle layer or elastic lamina. You can also have extramural venous invasion outside the muscularis propria, and that's a risk factor for liver metastasis. And that makes sense because once it's in those veins or that vasculature, there's a lot of vasculature that's obviously everything's going to run through the liver, kind of as a filtration system. A lot happens in the liver metabolically. So if you're having cancer getting into the vessels, it has a higher risk of going to the liver at some point. So in the image we have tumor filling large vein. So this is the vein here, and this is all malignant tumor within the vein. And then down here we have an orphan artery without its paired vein because the vein is filled with tumor. Sometimes you might just see the orphan artery and or a large rounded tongue of tumor next to it. So if you see just the artery by itself, which you know should have a vein running with it, that could be an indication to maybe get this stain, the EVG stain, which can highlight the internal elastic lamina of both the artery and the vein. And if you don't see large venous invasion, consider getting an EVG to look for it. So it can be tough to see like LVI, lymphovascular invasion, or large venous invasion. It can be difficult at times, but if we use various stains, sometimes that can help us point this out. And it's important to be able to find it because obviously it affects the prognosis for the patient and clinical management. So worth every second of the extra time that it would take to potentially find something like that. So for tumor budding is something else that you would report, and that is single cells or small clusters of less than 5 cells at the advancing front of the tumor. And that, as the name would suggest, right? You've got tumor budding off into these little components. So high tumor budding is a significant risk factor for nodal involvement and a poor outcome, and it represents epithelial mesenchymal transition. So poorly differentiated clusters are clusters of 5 or more cells without gland formation, and that's associated with worse outcome. Because remember, we talked about if it's able to maintain that glandular orientation, that's more well differentiated, but once it gets away from that gland formation and it's doing other things other than forming glands, it's a worse, higher grade and worse prognosis. Some other things that we want to be able to report in colon cancer, so lymph node metastases. You must have residual lymphoid tissue. It's usually rounded, usually has a rounded contour. So here we can see a metastatic lymph node. And whenever you get a colon cancer specimen at the gross bench, you're going to spend a lot of time smashing fat and finding lymph nodes because that's a very important part of our job, right? As pathologists, we want to be able to report how many lymph nodes we find and how many of those were positive or were negative. It's important to help the surgeons know that they got what they needed, and it's also most importantly important for the patient, right, to know is this cancer completely gone from my body, or is it potentially in the lymph nodes and other areas that I need to worry about. So tumor deposits. A tumor focused in the fat but without identifiable lymph node tissue, nerve, or vascular structure is staged as a PN1C. So often has irregular contours, and an unpaired artery or elastic lamina may lead you to think of large venous invasion. So let's talk a little bit about staging for colon cancer. So stage PT0, it means there's no evidence of primary tumor. PTIS means that there is carcinoma in situ or high-grade dysplasia. Intramucosal carcinoma, which is involvement of the lamina propria with no extension through the muscularis mucosa. Few lymphatics and low risk of Mets. A PT1 is a tumor invading the submucosa through the muscularis mucosa, but not into the muscularis propria, and this is usually going to elicit a desmoplastic response. So a PTIS, or at least intramucosal carcinoma, is less worrisome because our lymphatics and our vessels are in the submucosa. So once it gets to PT1, the tumor has invaded the submucosa, and at that point there's a higher risk of metastasis based on the histology and just the presence of lymphatics and vessels in the submucosa. PT2 is when the tumor invades the muscularis propria. PT3 is when the tumor invades through the muscularis propria into the pericolorectal tissues, and PT4A is when the tumor invades through the visceral peritoneum, including gross perforation of the bowel through tumor and continuous invasion of tumor through areas of inflammation to the surface of the visceral peritoneum. For PT4B is when the tumor directly invades or adheres to adjacent organs or structures. And in this example, even though the tumor isn't at the surface, because it's continuous with the surface through inflammation, it is PT4A. So here we see the mesothelial surface, and we have the colon cancer or the tumor here, and you would think those aren't quite touching, right? But the only thing between that is just inflammation. So there's no real integrity of the tissue to prevent this cancer from essentially being on the surface, right? So when it's just the only thing that is between the surface and the tumor itself is inflammation, that's considered at the surface, or enough to be PT4A. And that comes up a lot in tumor boards when you're discussing the resection with the surgeons and things like that. So again, very important to know. For ultimately, all of this is most important to report just for the care of our patients. So another thing is pseudoinvasion. So in pseudoinvasion, there's usually no or little cytologic or architectural atypia, and there can be inflamed fibrotic stroma with hemosiderin-laden macrophages and glands accompanied by lamina propria. Rounded and well circumscribed, and mostly occurs in the left colon. So it looks like invasion, but it's not quite invasion. So true invasion is usually going to have cytologic or architectural atypia with that desmoplastic stroma and an infiltrative or irregular growth pattern, and it's not accompanied by lamina propria. And this can occur anywhere in the colon. So for me, if I'm looking at something and I'm wondering is this invasive or not, the key thing that sticks out is kind of what Kurt already has underlined here, right? The desmoplastic stroma and the infiltrative and irregular growth. So that desmoplastic stroma is kind of that fibrotic and edematous response around these glands that is telling you that the tissue around these glands are responding to this malignant process because it's abnormal, right? There's atypia there. It shouldn't be there, and the body is responding, and that's why you have this desmoplastic response. And you see that elsewhere throughout the body with malignant processes. So desmoplastic stroma is a big clue in that you're dealing with invasion. So quickly, we'll go over everyone's favorite topic, some molecular. So for colon cancer, molecular is extremely important, and you can have the chromosomal instability pathway, which occurs in about 85% of colorectal cancer, and that's going to be the adenoma to carcinoma sequence with large chromosome arm gains and losses. So some common mutations for colon cancer are APC, which is early, starts the adenoma, activates the WNT pathway or the Wnt pathway, KRAS and P53. And RAS mutations in about 50% of tumors lead to resistant to anti-EGFR therapy, which can be used to treat metastatic colorectal cancer. So knowing about RAS mutation or any mutation for a colon cancer patient is good because you know certain therapies, they could be potentially resistant to them, like RAS and anti-EGFR therapy. The microsatellite instability pathway occurs in about 15% of colorectal cancer. So in the sporadic, you can have the BRAF mutation leading to MLH1 promoter hypermethylation, inactivation of the mismatch repair enzymes, serrated polyp formation, and then carcinoma. Or you can have the Lynch-associated pathway, which is a germline mutation and then MMR proteins, leading to loss of heterozygosity, adenoma, and then carcinoma. So there's lots of mutations leading to more immunogenic, more inflammatory response to tumor, leads to a better outcome. Also, response to checkpoint inhibitors, such as anti-PD-L1 drugs. So understanding the molecular of colon cancer and what the patient expresses is very important to know what kind of tumor you're likely dealing with and how they're going to respond, what therapies we can use to cure them, right? So the ultra-mutated pathway is about 3% of colorectal cancer, and that occurs with the POL, or the DNA replication enzyme mutation, which leads to lots of mistakes with DNA replication and an ultra-mutated tumor. And then lastly, we just have this section called rectal cancers stuff. So for rectal cancers, the quality of the surgical technique is a key determinant of local recurrence and long-term survival. Grossly, you want to assess the completeness of the non-peritonealized mesorectal excision and score according to the worst area. So for a complete mesorectal excision, you want to have an intact, bulky mesorectum with a smooth surface, like this specimen here, with no visible muscle, only very minor irregularities, less than 5 millimeters, and no coning, where the specimen tapers dramatically distally. So we see that clearly coning is not occurring here, so this is a complete mesorectal excision, excellent specimen. For nearly complete, you'll want to have moderately bulky mesorectum with minor irregularities but no visible muscle. And then for an incomplete excision, you want to have little bulk to mesorectum with muscularis propria visible. And here's an example of that coning and visible muscle. And that coning, as we discussed, was the specimen tapering dramatically distally. And that's what you don't want to see, but of course, the surgeon can only do what they can. And sometimes these tumors, it's really not the surgeon's fault. A lot of it just depends on how the tumor is growing within the patient, and we're all just doing the best we can to get it out of them and give the patient the best care possible. But sometimes the specimens come out looking different than others. So the circumferential resection margin is considered positive if the tumor is microscopically less than 1 millimeter from the inked circumferential margin, or the non-peritonealized surface. So that's it. Just a quick whirlwind of colon cancers based on Kurt's notes. I've really enjoyed making videos, and I hope you all are enjoying them too. Hope you have a good rest of your Sunday and a good week. And I hope that I'm able to make some more videos on this next month of SurgPath. So that's my goal. We'll see what happens. But in the meantime, like and subscribe, and take care.